Hi, everybody. I'd like to welcome all of you to this new broadcast of the ISCH Journal Club being held live today, 18th of October 2021. It's a few minutes past 7 p.m. in Paris, past 6 p.m. In London. And it is my great pleasure to welcome our two distinguished panelists for the purpose of today's Journal Club by the International Academy for Clinical Hematology, namely Professor Ana Sureda from Spain and Professor Mehdi Hamadani from the United States. Just as a reminder, the Journal Club of the ICH is supported through an unrestricted educational grant by Takeda Oncology. For today's Journal Club, the Scientific Steering Committee of the ISCH has identified this recently pre-published paper in Blood entitled Autologous Transplant versus Chimeric Antigen Receptor T-cell Therapy for Relapsed DLBCL in Partial Remission by Dr. Shadman and colleagues. So you can see the summary, the abstract of this really amazing work. And this is mainly a registry-based study using the CIBMTR registry database. And they have looked into adult DLBCL patients who received either an auto transplant between 2013 and 2019 or a CAR T-cell treatment with Axi-cell, and this is of course more recent, 2018, 2018, while being, and I think this is a crucial point, being in partial remission by imaging techniques at time of treatment. And the key messages, the key points from this study are shown here, is that if you consider DLBCL patient in partial remission after salvage therapy, auto transplantation and CAR T-cell consolidation provided a 2-year progression-free survival rates of 52% and 42% respectively in favor of the auto transplant arm. Another key important message is that in patients who are not heavily pretreated, so less or equal to 2 prior lines of therapy, there was no difference in terms of PFS and overall survival between the 2 groups. You can see, and this is table 4 from the paper, the multivariable regression analysis of outcomes in those patients receiving auto transplant and CAR T-cell. Obviously, age is always an important parameter for non-relapse mortality and toxicity. When it comes to progression or disease relapse, you can see that this is providing a good explanation for the PFS difference you see. And you can also see that there is clear trend in terms of PFS, but also overall survival. And you can see these beautiful curves, the non-relapse mortality between CAR T-cell treatment and auto transplant. And this is about the full study group, so all patients being included in this study. You can look into the probability of progression-free survival, probability of relapse or disease recurrence, and last but not least, overall survival. And the overall survival results are in favor of the auto arm. And actually, if you focus on the less heavily pretreated patient, well, it's going to be very straightforward. there is absolutely no difference between these two salvage treatment modalities, whether you consider toxicity, whether you consider disease relapse, or whether you consider overall outcome like PFS or overall survival. So as you can guess, these are really very important results. And this is a rapidly moving field, especially, and will bring us into this discussion today, that we had already press releases from phase 3 randomized trials comparing auto transplant and CAR T cells in DLBCL. So with this in mind, I would like to welcome our two distinguished guests, Professor Mehdi Hamadani, who is the senior author of this work. And I know, Mehdi, it's a very busy clinic day, and we're very grateful that you managed to sneak this journal club between a couple of patients. And we have also another expert, Professor Sureda from Barcelona in Spain, who did not participate in the study, but who is extremely active in the field of stem cell transplantation. She is the president-elect of the EBMT, and also she is a top expert in lymphoma. So thank you both for joining, and I would like to remind our audience that you can send your questions using the chat or the Q&A tab, and or comments or suggestions or whatever thoughts you have, and I'll be more than happy to share them with the panelists. So my first question as part of this journal club is to you, Anna. You didn't contribute to the study. I believe you were not necessarily aware of these results before their publication. And when you have read this paper being pre-published, what was your reaction? Was it like, wow, impressive, practice changing? Or you said, oh no, we have to wait for, randomized phase 3 trials. So what was your reaction?
So thank you very much, Mohamad. I think that my reaction is that I was really positively impressed with the results of the analysis. I did not participate in the study, but I think that in spite of being retrospective analysis, which maybe this is not the top 10 level of evidence that we would like to have, I think that these are really very important results in the field. So the field of lymphoma is moving very rapidly to CAR T cell therapy. So maybe in the next few years, I will have to change my profession to something else because I won't be transplanting patients with lymphomas.
But that means maybe we are curing more and more, and this is good news. I personally would love to change job if we can cure all patients.
These are very good news, but anyway, the reality is that the field is moving really very quickly. And I think that just because of the excellent results that we have with CAR T being used as third-line treatment, basically in those patients that relapse after an autologous stem cell transplantation or that are not candidates for an auto transplant, and they fail 2 lines of chemotherapy, there is the trend or the intention of the interest in somebody that has not achieved a complete remission after second-line treatment, which is the population of patients that Mehdi and the rest of the co-authors were looking at, move these patients rapidly to CAR T without considering that for many, many years, the standard of care has been autologous stem cell transplant. And I want to go back to the CORAL trial, which is quite old, and it was published in 2010. And if you look at the data of patients being in PR or CR before autologous stem cell transplantation, they did pretty much the same, and these patients were evaluated with CT scan. So why not to think that auto transplant, even with CAR T that seem to be more sexy, more attractive, any way of treating disease, auto transplant can be of value in these patients. And I think that this retrospective analysis is a very good example of that. So you compare those patients that achieve a partial remission, and maybe we can talk later on about the pitfalls of all the retrospective analysis. But if you compare face-to-face CAR-T with autologous stem cell transplant, auto-transplant is performing really well. And I think that this is a very important message to the scientific community and to all the transplant doctors or doctors that treat patients with lymphoma. So please don't forget auto-transplant in these patients, and of course take into consideration, let's say, some problems associated to the use of CAR-T. So I was really very favorably impressed with it.
Excellent. Thank you very much, Anna, for sharing your enthusiasm. You
know that I am always very enthusiastic.
Absolutely. And it is very important, actually, when we are treating such difficult hematologic malignancies, we need to be extremely optimistic and always enthusiastic, because we want to cure as many patients as we can. So now I have a provocative question to you, Mehdi, and this is the concept, of the Journal Club, is that you're bringing here a sort of a retrospective comparison based on the registry data, whereas we have heard recently press releases about state-of-the-art randomized phase 3 trials comparing auto to CAR T cells in relapsed DLBCL. So why performing such studies, such comparison, while you have the gold standard? Are there any differences? And when we will see the full results of these randomized phase 3 trials, is this article going, or this analysis going to be impactful? Can you share with us your thoughts?
Hi, good afternoon, everyone. And Mohamad, thank you so much for your kind invite. I'm really honored. It's an important question, right? Like, why do this analysis when likely at ASH we may have some readouts of the 3 CAR versus chemoimmunotherapy studies, and it was mainly from a practical standpoint. So if you look at the fundamental design of ZUMA-7, Transform, or Belinda, they're very different from PARMA trial, right? So PARMA trial makes the basis of our practice in aggressive lymphoma. A PARMA trial, when it was done, it only looked at aggressive lymphoma patients who relapsed and then happened to respond to salvage therapies, were then randomized to autologous transplant versus no further consolidation. And in those chemosensitive subset of patients, it showed that autologous transplant provided an event-free and a survival benefit. The 3 randomized trials are very different. So they're not randomizing chemosensitive patients to CAR consolidation versus auto consolidation. They're asking how to approach patients at the time of relapse. So it's technically a CAR versus chemoimmunotherapy question. And those studies, at least 2 out of 3 studies, seem to suggest an event-free survival benefit, likely because our salvage therapies haven't really improved over time. But our question was more practical. The way these lymphoma patients flow towards transplant or cell therapy centers is they often, at the time of relapse, may start salvage therapies locally. Most of these patients can't wait about 4 to 6 weeks to start CAR therapies, right? So we have to keep in mind that patients who went on ZUMA-7 trial went on the trial without any bridging therapy, right? And that's not every single DLBCL patients who relapses can't wait that long. So our question was practical. Our question was, in real life, when DLBCL patients relapses and let's say CAR becomes the standard of care in second-line therapy, what will we do for a patient who has started, let's say, rice salvage locally, and by the time the patient says Professor Sureda or Professor Mohty in your practices, they might have gotten 2 rounds of salvage and they're already in a chemosensitive response. Should those patients be consolidated with an expensive treatment like CAR, or maybe a potentially more cost-effective approach of auto-transplant consolidation might be reasonable? And here, I think that's essentially right now a data-free zone. And our data provides some guidance in that setting that maybe for a subset of those patients, auto-transplant is still reasonable. And the question we don't know is like, many patients achieve a CR after 2 rounds of salvage therapies, right? So for those patients, in my mind, it's a no-brainer. They should get an autologous transplant consolidation, and maybe it should be considered for patients who are just achieving a partial remission.
So what you're trying to tell us, Mehdi, is that, and this is really a pragmatic approach, that once you have a relapse DLBCL, the common sense approach would be to propose some form of chemotherapy as salvage while waiting to decide what to do. And in the group of patients who is going to be proven chemosensitive, then logically high dose chemotherapy will further enhance the benefit. And this is what is reflected in your study based on my understanding, compared to the other trials where we heard the press releases, but we have the design of the trials, on clinicaltrials.gov, where patients were just randomized between auto and CAR T cells, and that didn't take into account whether they have a chemo salvage or chemosensitivity.
Mm-hmm.
But then that brings me to a question, and I think we have a couple of comments about this from the audience, is that your definition of chemosensitivity is about achieving PR. But for me, although I'm not a lymphoma guy, PR in lymphoma is a sort of a wide concept, You can have a decrease of 60% of your lymph nodes, and that can be viewed as a PR, and you can have 90%. You have a bulky disease responding a little bit. You have the standard imaging, you have the PET scan. So Anna, how did you view this issue of PR having an influence or not on the reliability of this analysis from the CIBMTR?
Well, I think that this is one of the problems when we do retrospective analysis coming from registry, that we have to believe what the physicians call PR when they fill in the forms. That's one thing. And then the other thing is that we don't have an homogeneous way to evaluate this concept of PR. And in fact, I think that the manuscript elaborates quite a lot between those patients that have been evaluated as PR with CT scan and those patients that have PET-CT. Probably nowadays, almost all patients are being evaluated with PET-CT. The definition is there. It's not that we are calling PR completely different things from a daily clinic point of view, but it's true that when you don't have a control disease evaluation, you can always have some bias. But the definition of PR, it's already written down. I think that we are following the Lugano criteria. We are using PET-CT. It's always a retrospective evaluation. It's not a central review, which is basically what it's characterizing prospective clinical trials. And we have all this central review in the 3 prospective clinical trials that you have been mentioning. But it's not, but I would, let's say, I think that I would rely on the definition of PR being given in the manuscript that, by the way, it has been extensively analyzed here, and it's quite similar to the definitions that we are using in this type of retrospective analysis.
So Mehdi, same question to you. How reliable do you think your definition of PR, and whether you have used some sub-analysis in groups of patients where you have more reliable data to further give more confidence in your conclusions?
So we, Anna's point is well taken that, in registry analyses, we are dependent on data managers from the transplant centers to report these remissions accurately.
And we are very grateful to all data managers reporting to CIBMTR, to EBMT, and all other registries. They are doing really a great job, and we owe you a lot, guys.
Yeah. So I think like last year we had a paper published in Blood where we looked at DLBCL patients who were in partial remission with a positive PET scan. And even in that subset, the rough 3-year event-free survivals you see are very comparable to our data. But I would refer you to even a better quality paper from Craig Moskowitz's group in Memorial. So several years ago, they reported outcomes of centrally reviewed PET scans in DLBCL patients, and they stratified their outcomes based on Duvel 1, 2, 3, and 4. And Duvel 4 is roughly partial remission patients. And the 3-year progression-free survival of Duvel 4 patients in Craig Moskowitz's analysis was very identical to the numbers you see in the CIBMTR analysis. So these are some indirect data that suggest that the PR, the way the registry captures, at least provides you estimates that were published using more centrally reviewed data. And then in our analysis, like CIBMTR also captures the largest bulk of nodal disease at the time of transplant. And we adjusted our analysis based on residual nodal bulk. And even when we do that, the findings were very consistent.
Thank you very much. We have a few other questions, and now we'll dig a little bit deeper into these results, because obviously we'll not take everything for granted, you know, but this is the beauty of the research we're all doing, actually, very exciting. So here we have a couple of questions from the audience highlighting that when we look into the patient characteristics, the baseline characteristics of the patient you have studied, Mehdi, in table 1, for instance, well, actually the guys who received CAR T cells were slightly older, you know, the P level was, you know, borderline, but still, you know, they were roughly older, median 60 versus 58. And another important information from this table I can see, and that was significantly different between the two groups, is about the median number of lines of prior therapy. So in another word, we're concluding in general in the overall population that auto transplant is doing better than CAR T cells. But on the other hand, the CAR T cell patients are older and they are more heavily pretreated. So a sort of a devil advocate would tell you, well, this is obvious. They're going to do, you know, the outcome is going to be dismal if you treat older patients in more advanced disease. So what is your interpretation, and what are the explanation you can provide here in a defense of your results? And I'll ask the same question to Anna.
Yeah, I think this is a fair criticism, right? So the current FDA approval for CAR therapy in United States is 3rd line or beyond. And autologous transplant obviously can be applied to patients who are in a chemosensitive remission after 2 lines of therapy. So, and that was a fair criticism that was brought up by the peer reviewers of the manuscript as well. And we were asked to perform certain subgroup analyses. So in the manuscript, we looked at patients who received 2 lines of therapy before transplant versus patients who received more than 2 lines of therapy before transplant. And the results were consistent in those groups. In my mind, a more elegant way of adjusting for this analysis is to do a propensity score analysis. So in the supplemental table 5, we performed a propensity score analysis where the difference in age was no longer there. The number of lines of prior therapies was consistent. The interval between diagnosis and transplant was matched for, performance status was matched for, and the nodal bulk that was remaining pre-transplant was matched for. So after all these matching, when we looked at the outcomes of propensity score match subsets as well, again, we didn't see a major difference in favor of CAR in those therapies, which tends to sort of like validate the findings that there is some value in chemosensitivity. If your disease is responding to standard doses of chemotherapy, there may be benefit in then escalating and consolidating those patients with an autologous transplant.
Anna?
So, Mohamad, I'm not going to repeat what Mehdi has said, basically because he's the senior author of the paper, and of course, he knows the details much, much better than me. What I can say that after all these specific statistical analysis, being results of auto-transplant equal to CAR-T, I mean, it's very important. The important thing is not that eventually auto might be better than CAR-T in a specific subgroup of patients, is that the concept is that if you have somebody who is chemosensitive, you should not be scared of offering an autologous stem cell transplantation to the patient if, for instance, your access to CAR-T is not easy or you have other problems in between. So the results are pretty much the same, and this is important because we have been doing auto-transplant for these patients for many, many years, since the PARMA trial, that I was super young at that time when the PARMA trial was published. So,
but you are still young, Anna.
Oh, absolutely. So I think that this is really a very important message. It's not a question of saying, no, auto is better than CAR-T, is that auto performs the same as CAR-T in this population of chemosensitive patients that unfortunately will not be checked in the 3 prospective clinical trials that probably we will be looking at when we go to the ASH meeting, because as Mehdi has said, the design is completely different and they were not checking chemosensitivity of the patients. They were randomized up front.
Excellent. Thank you very much, both of you, for providing these important explanations that help for the interpretation of these results. When it comes to the interpretation, I think we have really an important question here, and unfortunately, the colleague didn't put his name, so it's an anonymous colleague, but the question is whether the 2 groups, Mehdi, the CAR-T and the auto, are balanced in terms of time from when PR has been attained until the time of administration of CAR-T or auto-transplant. Because if they are not balanced, there could be some so-called immortal time bias favoring the longer waiting to the procedure. And I think this is really a fair question. What would be your answer to this concern?
So it's a very good question, right? So this response assessment that we used as a PR pre-transplant or pre-CAR is a response assessment that was on the pre-transplant forms, right? And it defines, it's basically the instruction to the transplant centers is that this assessment needs to be done during or after the last round of chemotherapy or salvage therapy before transplant. So we didn't formally look at the interval of when the PET scan or CT scan was done versus transplant, but this is certainly data that is available. I would also point out that there were, I think, a handful of patients who got bridging therapy on the CAR arm, and none of those patients improved their PR to a CR. So there was no response improvement in those patients.
Excellent, thank you very much. And this journal club is really generating a lot of questions and enthusiasm. So I have here a question to you, Anna, from Dr. Jessica Voss, who apparently is already convinced about the value of auto-transplant. This is the way I read her question. And she's asking a fair and real-life question, given all the buzz and publicity around CAR T cells being the revolutionary treatment. And this is true, by the way. It's a huge breakthrough advance. How would you counsel patients, this kind of patient, and tell them, well, I still believe that the old-fashioned, style high-dose chemotherapy with 3 or 4 weeks of hospital stay with mucositis, with diarrhea is actually, I believe, the right treatment to you versus, the fashionable, fancy new CAR T cells?
I think it's going to be quite a difficult conversation after we see probably the results of at least the 2 positive prospective clinical trials, because this is one thing that we have not discussed, and I would be very happy to hear Mehdi's views. When you have somebody who is primary refractory or who has an early relapse, after probably coming back from ASH, we will learn that in this specific population of patients, for several reasons, CAR-T might give better long-term outcome than autologous stem cell transplant. And at some point, you have to make the decision at that time. So the paper that we are discussing today, it's a kind of dynamic paper. So we are basing our decision eventually to go ahead with an autologous transplant to somebody that has already demonstrated chemosensitivity before the procedure with salvage chemotherapy, which is one thing that we are not going to see in those patients that have been included in the phase 3 prospective clinical trials. So I really don't know, but the conversation probably is going to be difficult, and maybe let's say the availability of CAR-T, which we know that it's not 100% in all the centers, and eventually some potential exclusion criteria, that there are not so many exclusion criteria for CAR-T. So we have to be fair on that. So age is not a major issue, and of course the toxicity profile is quite acceptable. Maybe these things will play a role when discussing the different options with the patients. But after having said that, I think that the results from the randomized clinical trials will play a major role in the, let's say, even what the patient will be coming and requesting you when they come to the office or to clinics.
No, thank you very much, Anna. This is important. I think you mentioned access to CAR T cells, but we have also several comments about the cost. And actually today, at least in European countries, in low and middle income countries, the auto transplant procedure is really well established and affordable in general, in contrast to CAR T cells. You also mentioned, Anna, the issue of age and toxicity, and we have a couple of questions from Dr. Brizou, from other colleagues about the age and frailty patient. I mean, when I look to your table 1 again, Mehdi, the upper limit age for CAR T cells was 91. So you can give CAR T cells above age 90. I have rarely heard, to be honest, about an auto transplant above age 80, for instance. And actually, this is the limit you have in your auto group. So would it be possible that we will have progressively a sort of a separation where if you are chemosensitive, relatively young and fit, this is going to be auto. If you are older, maybe more frail, still chemosensitive, you would rather go to CAR T cell treatment, just speculating.
Yeah, was it a question for me or Anna?
For you, and then we'll go back to Anna.
Yeah, I
think
like
you, Mehdi.
Mohamad, it's a good point, right? Because I'm a big proponent of one size doesn't fit all, right? And this CIBMTR analysis it's not a perfect analysis. I think it's more thought provocative, and for certain patients, it's not practice changing. It might be practice validating, right? But you're right. Like if there is a 85-year-old in partial remission, are we going to autograft that patient? And the answer is no. We can arguably give that patient CAR T cell therapy safely in an experienced center. And there are certain other biological parameters, right? If I see a bona fide double hit diffuse large B-cell lymphoma in a partial remission, would I be excited about autografting that patient? And the answer is absolutely not, right? We have data from Philippe Armand and Alex Herrera in JCO several years ago that showed that these partial remission double hit patients don't drive lasting benefit from an auto transplant. And I think those are patients for whom if CAR therapy is available in second line, that would be useful. And the third group would be several years ago, Luciano Costa did that analysis called REFINE analysis, where we looked at these early relapsing DLBCL patients. And we identified 3 risk factors as predictors of auto failure, even with chemosensitivity. And those were if you were getting progression on R-CHOP therapy as a best response, patients who had high NCC and IPI score at relapse, or patients with c-MYC gene rearrangements. So if you had 2 out of these 3 risk factors, even with chemosensitivity, autotransplant's long-term benefit was 15%. And if I see such a patient in my clinic now, if CAR was to become available in second-line therapy, I would not be excited about giving autotransplant to those patients. So I think there are patients where I think auto still makes sense, and there absolutely will be patients for whom CAR in second line would make better sense.
So Anna, today, what are in your practice the current indications for auto transplant? Because you have both CAR T cells and auto transplant available in your center. What are the indications?
So basically, we continue with auto transplant as, let's say, consolidation after salvage therapy in those patients that achieve a complete remission or a partial remission. So we are still considering that for an autologous transplantation. We consider CAR-T for those young patients that fail an autologous transplant, and we go back to this concept of age limit, which I think it's very important and may also impact what's going to happen when we see the results of the famous phase 3 prospective clinical trials, because they were designed for transplant eligible patients. So in some ways, there was an age there. And we also consider CAR-T for those patients that are not candidates for an autologous transplantation and that fail 2 prior lines of therapy. So I would say that that's the standard indication right now. Of course, we look very much in depth nowadays, somebody who has an early relapse or who is primary refractory, because we know that these patients will have more difficulties in achieving a good response with second-line treatment. And although we are not at least in the process of collecting rainy days lymphocytes, as we did many, many years ago, for instance, for follicular lymphoma patients that were supposed to be candidates. This is one thing that we are looking really very closely, and maybe this is one thing that will be done in the future. Excellent. With quite a lot of costs, I have to say too.
Yeah, absolutely. That's also another problem, the affordability of all of these wonderful treatments we are able now to deliver to our patient. We still have a couple of minutes, so I would like to ask both of you to look into the future. And actually, we have several questions. I can see here a question from Dr. Lanza from Italy, but many other colleagues, Dr. Syed and many others, asking the question whether actually instead of opposing and comparing auto to CAR T cells, is there any room for combining auto transplant and CAR T cells? I don't know, what are your thoughts?
Mehdi, you come first.
So I'd refer you to the memorial looked at that question of auto transplant followed by cell therapy infusion. I believe Miguel Perales was the senior author on that paper, and it is feasible, but there was a definite neurotoxicity signal, which might be a factor of the CAR construct you're using. So there is some merit in that question, but people have looked at this question. Would the field necessarily go in that direction? I'm skeptical.
Anna?
Me too. I think that we don't have a lot of data, so it's quite a lot of speculation here. And the reality is that apart from CAR-T and from autotransplant, we also have very effective drugs that we have not been discussing in the field of aggressive lymphoma and in other types of lymphomas that might play a clear role in the future. So I think that we are lucky enough to have quite a variety of different treatment strategies that might be very useful for the patients. And Mohamad, I don't know if we have 1 minute left, but I think that an important question is looking into the future, how we are going to deal with patients that fail CAR T, being CAR T used as second-line therapy, which is one thing that may happen, let's say, when, let's say, CAR Ts move to second line, if the results of the phase 3 prospective clinical trials are convincing enough, which I think that it's going to be the case, because we will be facing patients that would have received only a little bit of chemotherapy with not a lot of luck, because they will be high-risk patients, and that eventually fail CAR T, that it's another way of treating patients, but has only kind of lymphodepleting patients. So I would like to know, what do you think about these patients, Mehdi? Because they will represent, let's say, a significant number of patients, because I'm sure that patients will be relapsing after CAR T being used as second-line treatment. So we will have to reinvent a little bit ourselves and to change the treatment paradigm of patients with diffuse large B-cell lymphoma in some years from now.
I agree, and like we'll have to learn how to sequence these therapies, right? Because the reason I'm in favor of doing autografts in chemosensitive patients is because even if they fail an autograft, you can do cell therapy after auto transplant failure. It's more difficult to do auto transplant after CAR failure, and it might be different. Anna has a good point that if CAR is being applied in second line, maybe those patients may not be very heavily pre-treated, and if they happen to respond to therapies down the road, maybe those patients might be salvageable, and maybe auto transplant may be feasible in those patients. We have a lot of data of allo transplants in CAR failures now, and it is helpful for a subset of patients. But I think that will really impact our practice are going to be bispecifics, right? So the data with glofitamab and at least epcoritamab, it looks exciting. The patients who are achieving complete remissions, these remissions appear to be durable. So in my conversations with those sponsors is like, I know second line salvage studies, phase 1 studies of combining BiTEs with standard chemoimmunotherapies are being planned and will be started soon. So if you, all of a sudden, if you start to have a salvage therapy, which is giving you much greater responses than what RICE or DHAP gives us now, then it would start to challenge the relevance of these phase 3 studies as well. Let's say if we have a salvage platform that is giving you 80-90% responses, then we may have to rethink our strategy. But in the absence of a very powerful, effective salvage therapy, Anna is right. I think a good subset of patients, if approval comes our way, may be good candidates for cell therapy in second line.
Well, this is a fascinating discussion, and I believe the case is not closed. The debate will continue to be hot, and it is going to become hotter and hotter after, I guess, the release of the data from the next ASH meeting. So definitely the International Academy for Clinical Hematology is committed to disseminate and spread the knowledge, but also to stimulate this very important debate, because this is extremely crucial to our patient, because you are deciding, we are talking today on how to cure more and more patients. And this is a crucial and very important parameter, of course. So I promise we'll have more discussions. Maybe I'm thinking about a very large panel discussion with different experts to address this, maybe after ASH, knowing more details. So I hope, I do apologize that we were not able to take all the questions. There were dozens of questions. We couldn't handle the artificial intelligence role in deciding treatment and so on, but all of these are very smart and nice questions. So I'd like to thank our top expert panelists for sparing some time with us today. Congratulations again, Mehdi, for this really beautiful blood paper, which will be very impactful. I mean, we can see it today from the enthusiasm and lots of questions that have been posted. Thank you, Anna, for joining us, and thank you all for being loyal and for following the ICH activities. The Journal Club is every 15 days, but please don't forget our monthly webinars. Tomorrow, I think we have a very nice webinar on the state-of-the-art treatment of CLL by Dr. Nitin Jain from MD Anderson. So CLL treatment is really moving fast, and also, you know, chemotherapy is becoming a sort of an old-fashioned thing in CLL, like we were debating in DLBCL here in lymphoma. So with this, I'd like to thank you all for following this ICH Journal Club. And as usual, you know, my conclusion, wherever you are, please stay safe and keep well, and hope to see you soon. Thank you very much.
Thank you, Mohamad.
Thank you. Thank you.